He is a specialist in and a doctor in physiology and specialist in autonomic medicine. He has over 30 years of experience. He is also an engineer. He has several publications, including with Dr. Dipachi, and he is well published in the field of autonomic nervous system. He's going to be talking about the topic on dysautonomia. So, Dr. Joseph Columbo.
Almost every cell in the body. As a result, one of the reasons why is the autonomic nervous system, because it controls the systems. If it's out of balance, it can mimic other disorders. So one of the things that we have to do with autonomic dysfunction is determine what part is dysfunction, bring the nervous system back into balance, and then whatever is left is the actual end organ dysfunction or disorder. So we've had patients that come in looking like they have lupus, for example, but they actually then, when we balanced their nervous system, all the lupus symptoms went away. So that was 100% dysautonomia. But then there's the other end of the spectrum where we treat them and none of the symptoms go away, and that's true lupus, and they go back to Dr. Solomon. So balancing the nervous system helps to stabilize and normalize the patient so that if there's anything left over, then it's true. Going back to asthma with Dr. Kunani, autonomic dysfunction, mast cells or immune cells, the parasympathetic nervous system controls the immune system, and if the parasympathetics are overactive, you're going to have too many mast cells released, and that, if it happens in the bronchi, you can wind up with asthma, or at least asthma-like symptoms. Relieve the parasympathetic excess, the mast cells go back to normal, whatever's left over is true asthma. Then Dr. Kunani can be more aggressive about treating the end organ dysfunction. So, while it's going to sound like the autonomic nervous system is the panacea and the answer to the world, it's only part of it. Don't ever let anybody think it's the end all and be all. So, what is taught in medical school is very little. When I was in medical school and got introduced to the autonomic nervous system, I realized it had held a lot more information, and therefore started doing much more research into it and developed things that we're using nowadays to be able to test it. But probably the biggest problem that came out of medical school is it's two branches and you have to be in balance. So balance, seesaw. If you think of it as a seesaw, you're going to assume that the two branches are working in opposition to each other. They're trying to compete with each other. That is not the case at all. They're cooperative. That's the reason why we moved from a seesaw model to the car model that Dr. Dipachi alluded to. It's not just the brakes and accelerator. You know, if you think of you're sitting at a red light, foot's on the brakes, light turns green, the first thing you do is you take your foot off the brakes, right? Well, by taking your foot off the brakes, you're minimizing the amount of gas because you start rolling before you even touch the accelerator. That minimizes the amount of gas. Think of that as adrenaline. We know too much adrenaline in the body's not good. And then it potentiates the acceleration, the sympathetic side, which we know is supposed to be short-lived and very low amplitude. You don't want a whole lot of fight or flight. You don't want a whole lot of stress. But if you keep your foot on the brakes, and because of trauma, because you ever drive behind somebody who's hitting the brakes constantly for no apparent reason, that's a little frustrating. Well, a lot of patients, that's their body. That's what their body's doing. They're in full-on protection mode. They're constantly hitting the brakes. So that means they have to over-accelerate to get everywhere or anywhere. Problem is the over-acceleration is what most of the rest of medicine sees. But that in those cases, the over-acceleration is actually the compensatory mechanism, not a symptom. and we believe, or at least I believe, it's the reason why half the world's hypertension population is poorly managed. Because the over-acceleration is not the problem. It is a problem, don't get me wrong. But it's not the primary problem. It's trying to compensate for the fact that someone's hitting the brakes all the time. And you're not getting enough blood to the brain, you're not getting enough blood to the heart, whatever the case may be. So, the good news is all autonomic dysfunction is treatable. Working with Dr. Apache and hundreds of other doctors around the world, we've come up with treatment and therapy plans for every autonomic dysfunction, whether it's prescription grade or not. A lot of our patients come to us on such high doses of medication that they don't respond to the low doses that we would need to use. Autonomic dysfunction has to be low and slow. I explain to patients it's like trying to correct a swinging pendulum. If you hit it hard and knock it off its hinge, you create more problems. It's got to be low, easy, little, slow, gentle nudges over time. So if they're on high doses of the medicines we want to use, they're not going to respond to that. So we went off into the alternative world, supplements and lifestyle changes. So it turns out there's 6 pillars, as some people call it: diet, exercise, and stress reduction on the lifestyle changes, and then antioxidants, nitric oxide boosts, and omega-3 represents the anti-inflammatories. A lot of pain associated with autonomic dysfunction is due to inflammation, including inflammation of joints, which can mimic rheumatological disorders, as another example. So we move to the car analogy. Have to think of it as 3 parts. Parasympathetics are the brakes. The alpha sympathetics, the sympathetics outside the rib cage that primarily control the vasculature, is like the fuel pump in the car, getting gas from the tank to the engine, or in this case, blood from the feet to the abdomen. And then the beta sympathetics, which control and coordinate what's inside the rib cage, the heart, the lungs, and that's the accelerator. So, parasympathetic and sympathetic dysfunctions, including long COVID, as Dr. Apache expounded on. You have this parasympathetic excess. It's kind of like driving the car with the foot on the brakes. Alpha sympathetic withdrawal, which is that sympathetic insufficiency that's not permitting the proper vascular vasoconstriction to move blood, as Dr. Soloway alluded to, and sympathetic excess, that over-acceleration, the overdrive of the heart. So, one of the common things, especially in long COVID and other complicated autonomic dysfunctions, including diabetes, PTSD, concussion, etc. Basically, the seesaw's broken. Both ends are high. You know, that's a bad state, right? And you have to treat both. Remember, though, that the parasympathetics are the driving force. They're the reactive nervous system. They set the threshold around which the sympathetics react. The sympathetics are the reactive nervous system. So parasympathetics, like the brakes, if you take your foot off the brakes, you don't have to over-accelerate. If you keep your foot on the brakes, you'll end up over-accelerating. So, yes, this is a very complicated slide. But this is a very complicated, these are very complicated patients. I'll pick on Dr. Fernandez a little bit here. When he first started coming and shadowing us, I would show this diagram to patients, and the patients got it immediately. They totally understood how all 40 symptoms that they have the majority of can boil down to only 2 autonomic dysfunctions. Dr. Fernandez, looking at it from a doctor's point of view, I finally had to tell him, this is like the 301 course. Let's back up to the 101 course and build this up to you. But basically, what we're saying here is, here's your accelerator. Okay. The SE, the sympathetic excess, the reason why it's in a smaller box is that's the accelerator. That's compensating for the 2 bigger boxes, the parasympathetic excess, PE, blue, on the parasympathetic side, and SW down below. SW is kind of the bottom half of the problem. Parasympathetic axis is the top half of the problem, trying to get blood from the feet to the brain. So, heart rate, blood pressure, inflammation, histamine, pain, blood sugar, anxiety, syncope, those in the autonomic world tend to be compensatory. They're not the primary disorder. It's like with POTS. The tachycardia in POTS is not a symptom, it's a compensatory mechanism. As a matter of fact, unless you're heavily beta blocked, you do not faint from POTS. However, about half of all POTS patients also have vasovagal syncope. That's the vagal side, the parasympathetic side. If you're not measuring both branches, you're just measuring the total autonomic function. You don't understand that, you can't measure that. This is why doctors will say, I don't know what's causing it, because they can't, they don't measure it. And then they try to treat your symptoms, and oftentimes patients feel worse because the symptoms are not symptoms, they're compensatory mechanisms. So sympathetic withdrawal leads to poor coronary perfusion, and the two of them lead to poor cerebral perfusion, and behavioral health issues, ADD, ADHD even, as well as brain fog, memory cognitive difficulties, headaches, migraines, coat hanger pain, the list goes on and on. They can all be understood and described by autonomic dysfunction, but it may not be only autonomic dysfunction. So just keep that in mind. The biggest adversary to all of this, from an autonomic point of view, is stress. And the reason why, because it takes a long time, think of treating the autonomic nervous system like trying to break a bad habit and establish and maintain a good habit. That's not a 10-day fix. It's going to take a couple of months. That's why the autonomic changes and therapy take a couple of months. And if you cheat, right, you're trying to break the habit of eating too much candy. 2 weeks in, you have a piece of candy, you almost have to start over again, right? Well, the stresses are kind of like that candy. And the problem is half of the stresses are internal. You can't run away from them. So until the patient relearns their body, they have a hard time feeling better. But until they feel better, and they start getting well from within, the beauty from without is hard. You ever see a depressed or a fatigued person? They could be they could be a model, but they're not looking like a model because they're not feeling good inside. So from an aesthetic point of view, wellness from the inside helps to get people looking better because they're feeling better about themselves. The autonomic nervous system can predict disorders because the nervous system's job is to maintain normal function as long as possible until even if the nervous system itself is abnormal. So I use a thermostat analogy. It's, say you set your thermostat to 70 degrees, like 70 beats per minute for your heart rate. Let's say it's a hot, humid Philadelphia August day, and the air conditioning, the cooling system's working well, but the heater system switch fails and the heater comes on for poor. What happens to the temperature? Nothing. The cooling system's going to amp up to compensate for the ambient temperature plus the fact that the heater is on. So you're still reading 70 and you think everything's fine until one of the other systems fails. Now the temperature changes, but that's too late. We're actually measuring the two systems and their switches, and this is how we can get some insight, like with long COVID. Patients that have COVID and survive, we can test them, and we can predict who's going to get long COVID and who's not, based on the state of their autonomic nervous system. So, it's important to measure both branches, not just the total autonomic function, so that we get more insight. One of the things I did early on with Dr. Aaron Finnick, who developed the whole concept of diabetic autonomic neuropathy, was compare
300 normal patients to 500 diabetic type 2 patients, about half of them being female. The broken lines up towards the top, blue being parasympathetic, red being sympathetic, shows the normal, healthy, if you will, aging effect on the autonomic nervous system. Everything declines as we age, we know that. Notice with the diabetics, starting at age 25, they've already lost about half of their autonomic function. And by the time they're age 45, when it finally becomes symptomatic and the patients start listening to us, they're down to almost 80% autonomic loss. And then they start listening to their doctors, and look how flat those lines get until aging catches up with them. I don't know if this is going to work. No. In some presentations, I thought I put it in here. The next click, this flat part actually translates up. No, there it goes. You convince them to start listening to you earlier, you can actually buy back that 20 years the autonomic dysfunction takes away from the patient. So, you need to measure both. Again, as Dr. Solomon says, if you don't get a proper diagnosis, you don't know what you're treating. Parasympathetic excess and sympathetic withdrawal are the primaries. Sympathetic excess, which is, look at, everybody else measures that, right? Stress, heart rate, blood pressure, inflammatory markers were asked about, histamine, all of these pain, all of these things is what the average doctor measures all the time. And that's sort of a stilted view on the autonomic nervous system. So, some of these have been already mentioned today, but all of these are types, or can be types, of autonomic dysfunction. POTS, orthostatic dysfunction, mast cell overactivation, or MCAS, autoimmune disorders, inflammatory disorders, GI disorders up and lower, small fiber disorder, hormone imbalances. Someone asked about hormones and endocrinology. The hormones are controlled by the parasympathetic nervous system. It turns out, of all the thyroid patients I've tested over the years, hypothyroid patients, the ones that have parasympathetic excess, I'm actually able to reduce their synthroid levels by relieving the parasympathetic excess, and about 15% come all the way off synthroid. So apparently the parasympathetics are involved in maybe shutting down the thyroid in these cases, as an example. Women's health issues with hormones, growth hormone issues, all of these things are affected by the nervous system. Difficult to manage weight is another, can be associated with parasympathetic excess. Poor coronary perfusion, as we talked about, poor cerebral perfusion. And as I've been saying, the sympathetic excess-based dysfunctions are compensatory. So, patients are complex, many symptoms, but really it only comes down to these three parts of the autonomic nervous system. You bring all this back into balance, you're probably going to cure 15% of your patients. You're going to relieve a lot of the symptoms in another 70% of your patients, and whatever is left is true end organ dysfunction. So, folks in the dermatology world always talk about hydration, right? Well, as I tell patients, don't mean to be, don't take this personally, but we're all bags of water. We need to be about 60% full. If we're not, and most of the autonomic patients, I would guess, are at 40% full. And if you're drinking a gallon of water a day, but you're going to the bathroom more than 4 times a day, that water's not staying inside you, and you need electrolytes. And depending on your blood pressure, it depends on the type of electrolyte you might need. So, and then alpha-lipoic acid has been mentioned rather. There are 2 types of alpha-lipoic acid, one for plants, S, and one for animals and humans, R. Unfortunately, most of the R comes out of China anymore, so it's hard to get the R, you really have to look. But it's unfortunately both because both are still alpha-lipoic acid. The FDA doesn't require those companies to differentiate how much is R and how much is S. So over the years, especially the last 3 or 4 years, the amount of R in these pills have fallen off, and this is why people are not feeling as well, because they're not getting the type that's useful for humans. Someone mentioned NAD. The reason why ALA and CoQ10 are the prominent ones that we recommend is that ALA and CoQ10 not only are the 2 most potent antioxidants that your body makes naturally, but those 2 will also recycle all of the others. NAD, vitamin A, vitamin C, vitamin B, glutathione, et cetera, and making not only those more potent, but also ALA and CoQ10 more potent. And because of all the other supplements and things that patients need to go on to get started, being sensitive to the economics of all this, we remind them about the recycling. So if they're eating a healthy diet and getting enough antioxidants through their diet, and then they take ALA and or CoQ10, they don't need to take additional pills for all the other antioxidants. Sorry, going backwards. Okay, so, questions. These 2 books, so Dr. DePace and I, the second book we wrote goes totally into the non-prescription grade therapies that we recommend. But that went deep into biochemistry, mostly to convince ourselves that we can use it as prescription grade. As an example, the alpha-lipoic acid was actually the therapy developed by Dr. Vinnick for diabetic autonomic neuropathy 25 years before any of the other vasopressors came out. Pharmaceuticals couldn't make money off alpha-lipoic acid, so they went off and produced other agents that can retrain the nerves from without. So, yes?
I'm interested by your slide that says they're treating blood pressure incorrectly. You're saying if our blood pressure is less than 160/90, they should take more sodium. In what form would you recommend as an electrolyte?
Well, the least expensive is just salt, plain salt, even flavored salts. You need 5.5 grams of electrolytes, either potassium or sodium, to help keep it spread throughout the day, to help keep water in your blood vessels. So if it's in the form of sodium, salts are a great source of sodium. It turns out 1 full tablespoon in half a gallon of water drawn throughout the day, 8 ounce glasses, gives you about the half teaspoon every 2 hours that you need to keep water in your blood vessels.
Could we eat something like pretzels or things
Yeah,
like that?
you can have a handful of salty snacks. It's just, you got to carry that around throughout the day. And if you're talking to a bunch of students, they have problems keeping water in the classroom, let alone snacks in the classroom. So,
Do you see in the blood, like when you check the blood work, the sodium level is low, or it doesn't affect the sodium level?
it doesn't seem to affect the sodium level much, or even the potassium level.
Potassium?
Yeah, potassium if your pressures are high, because that'll keep water in your blood vessels and help lower your blood pressure. And a lot of our autonomic patients, their blood pressures are low to begin with. They're already down around 100/60 or less, especially if they have orthostatic hypotension before the resting pressure rises as a compensatory mechanism due to the sympathetic excess.
But if you increase the sodium intake, would it affect negatively fluid retention and all the other stuff that comes with?
Well, if they're having a problem with keeping water in their blood vessels, it's not a negative effect, it's a positive effect. But this is part of the reason why I do a lot of work in cardiology offices, because I'm not a cardiologist. So make sure that the cardiologist is comfortable with whether it's potassium, because potassium can also have negative effects too, depending on other comorbidities. So you got to take all this into account and work with the right specialist.
How about like proteins? Would proteins help in any way or form?
haven't seen where it's as effective as the sodium. Other questions?
One question, would this autonomic dysregulation also affect mental status? For
Absolutely.
instance, aggression, agitation, irritability. We treat a lot of psychiatric patients who are on
Right.
a multitude of psychotropic medications, atypical antipsychotics. So some of the things we do see is orthostatic hypotension and difficulties with behaviors. So I know previously it was alluded that the autonomic nervous system does control behavior. Dysregulation will cause that. So having a psychiatrist also recognize that this is happening at a systemic level, not just supratentorial.
Right. I've been working the last 4 to 5 years now with Rutgers Psychiatric Department, and they are fully convinced that if you've been on an antidepressant or anxiolytic for more than 6 months, you don't have a purely psychiatric problem, it's autonomic. One of the easy ways to think, it's a little bit over a generalization, but depressed patients have no problem sleeping. Autonomic patients take forever to get to sleep. That's because as soon as they lay down, their brains get all the blood at once. The brain wakes up and wants to play. Patients tell me they're more active and alert trying to fall asleep than they were all day long. That's because their brain's finally getting all the blood at once. Upright, the heart's fighting gravity, and now your brain is marginally perfused just enough to keep you awake, but not fully active. The anxiety, the adrenaline storm, cycles the anxiety. Anxiety in these patients are periodic, episodic, compensatory mechanisms. There's a doctor in Collingswood that retired 2 years ago. We've been hoping he would come to us once a week, but he and I have been treating and curing ADD, ADHD, OCD, and even high-functioning autism by getting more blood to the brain, because those are chronic ways of the brain calling for more blood. Those 2 or 3 hour exams we took in school, you walk out feeling like you ran a marathon, right? But you sat for 2 or 3 hours. What's that all about? Well, that's how much your brain requires in the form of resources. If it's not getting all of that, it's going to act that way so that it calls for more blood all the time, which mimics ADD, ADHD, OCD, and high-functioning autism and anxiety.
So would you recommend that anybody that potentially has these psychiatric diagnoses should at some point get evaluated for autonomic dysfunction?
I'm not sure.
Especially if they're chronic.
I'm not sure to the point of saying that emphatically, but Rutgers is working that way. Look, the reason why Rutgers got into this with me, one of the reasons, because of long COVID especially, it's expected that in the next 4 years, we're going to need 6,000 more psychiatrists. And right now, there's less than 2,000 coming through the pipeline, and I think almost half of those may not actually go into practice.
Because I recall that when COVID first started, there was some data that there's almost a 66% prevalence of new diagnosis for psychiatric illness in the setting of COVID infection, and vice versa, that patients who have pre-existing psychiatric illness tend to have almost 66% increased likelihood of complications from COVID infection.
Yeah. So yes, not enough blood to the brain. Mimics, your brain's having sleep all day, so you're going to have depression-like symptoms. And then you have that adrenaline storm or that hyperactivity to try to call for more blood, and it mimics the other. So bipolar, ADD, ADHD, depression, anxiety, we've been curing all of that stuff as a side effect, if you will, of balancing the nervous system. Whatever is left, of course, is the true psychiatric